welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, When Dreams Become Nightmares, Pediatric Narcolepsy. Today's program is supported in part by the Pediatric Pulmonary Center at the University of Alabama at Birmingham. If you have any questions about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credit will only be awarded for 1 year for nurses, expiring on April 30th, 2019, and 2 years for social workers, expiring April 30th of 2020. And now, let's meet our faculty presenters today. Dr. R. Bradley Troxler is the Associate Professor of Pediatrics at the University of Alabama at Birmingham and the Director of Pediatric Sleep Disorder Center at Children's of Alabama. We also have Heather Thompson, and who will discuss what it's like to be a young adult affected by narcolepsy, and her mother, Lori Thompson, will provide some insight on being a parent of a young adult affected by narcolepsy. Welcome, and thank you all for being here. Let's get started with Dr. Troxler.
Thank you. Thank you for joining us today as we talk about pediatric narcolepsy. Before we get started, I don't have any conflicts of interest to disclose. There's no pharmaceutical money or any other monies that have been given to me to influence the topic that we're discussing. Our objectives for today's talk is really to talk about the epidemiology of pediatric narcolepsy. We'll spend some time reviewing what the signs and symptoms are of this sleep disorder. We'll discuss the pathophysiology, and we'll highlight some of the ways that this complaints might be assessed, and ultimately how to diagnose narcolepsy. And finally, I'll talk about the treatments for narcolepsy and the different symptoms of it. Before we delve into that, though, as mentioned, we have two experts with us, both Heather Thompson and her mother, Lori. Heather, as was mentioned, was diagnosed as a adolescent with narcolepsy, and so she and her mom both are really the experts here. And so I have a few questions for them to kind of highlight what is pediatric narcolepsy and how it's impacted their life. After we kind of have some discussion back and forth, we'll delve into some of the science, and ultimately today we'll conclude talking back with our experts about what they've learned on their journey and things that they wish they could share with everyone. So first of all, Heather and Lori, thank you for joining us today. We appreciate it. The first question really is for both of you, but Heather, I think you're probably the person most that want to know is, how did your symptoms begin? Like, what led you down this pathway toward a diagnosis of pediatric narcolepsy?
Yeah, well, it was a bit difficult to actually pinpoint when my symptoms began. Growing up, I dealt with several other chronic health issues like persistent asthma and celiac disease and juvenile arthritis, which had all been diagnosed prior to the narcolepsy diagnosis. And so for a number of years, it was difficult to distinguish between fatigue and sleepiness. But when I was in 9th grade, which was 5 years ago, the symptoms of sleepiness and that indicated narcolepsy became more persistent, and we really began to, as a family, notice that this was probably something that was not associated with just the fatigue that could be accompanied with my other diseases, but that this might be something of its own. And so 9th grade year, really more severe symptoms started showing up, and then it took about a year to reach that narcolepsy diagnosis.
What kind of symptoms were you having that 9th grade year that really were so profound?
Yeah, I'd wake up and go to school, and then when I came home about 3 o'clock, I would immediately just feel this overwhelming sleepiness and have to sleep for a couple hours, waking up at 8 or 9 and then starting my homework. Or there were other mornings where it just felt like I couldn't get myself even up and out of bed and going in the morning. I just noticed this increasing kind of driftiness or fogginess in my thoughts, like I wasn't able to keep attention or focus like I used to be able to.
Did those symptoms, did they really impact your life at that point? Like what did you have to do because of that?
Yeah, I did. as it got worse and I was missing more days of school and falling behind in my schoolwork, my mom and I met with my principal, and we really discussed that the only option left available to us was to take a step back from school for the time being. So I withdrew from school and homeschooled the rest of the year to catch up on the work that I'd missed at my own pace. But it was life-altering. I was taken out of my day-to-day routine, involved in the sports that I was doing in tennis. I wasn't able to do that anymore. I was at home, away from my friends, and it took several months to figure out what was going on.
So how did you start to figure this out? What did y'all do? Who did you turn to for help? And you may need help from your mom on that.
Well, I actually first began to raise the question of a possible sleep disorder when Heather was in the 6th grade and began to have trouble getting up in the morning and getting going and getting to school. But as Heather shared, there were other disorders that we were dealing with. For instance, that 6th grade year, she missed 26 days of school. And but one of the things that came out of that year of asking questions and saying what's going on is, for instance, her asthma was reclassified as severe persistent, and she began a medication called Xolair, and that did begin to get the asthma component, and she was able to get back in and pretty much get back to a normal lifestyle until that 9th grade year. And we really just felt that, she was just on a wheel. A rat on a wheel, and it's like, let's just back up until we can figure out there's something else here. And even though I had kind of been mentioning a question of sleep, even based on looking back into early toddler years and just restlessness, I got to a point where I wasn't just asking the question, I was really demanding. It's like I didn't know any other questions to ask. That was the one thing we had not fully explored that had been on the table, and we would get our attention diverted away from it. And so I knew the time had come to really say, it's got to happen. She's got to see a sleep specialist. Let's do a study. There's something else.
And so you got in to see a sleep specialist, and what happened after that?
Really pretty quickly after the sleep study, the diagnosis came quickly, and immediately there was a huge psychological just release. It had been so difficult for so many months, not understanding what was going on with myself, and being out of my normal routine and my normal life and not having really an answer to give people as to what was going on. And then we began the process of figuring out which medications would work best for me, which took a little bit of trial and error. I tried some at first that kind of gave me a more jittery or wired feeling and not really restful, almost as if I had a couple hours of sleep and I was given this energy drink. And so I wasn't falling asleep, but I didn't necessarily feel like I had a restful night. But eventually, within a couple of months, I arrived at a regimen of medication and dosage that worked really well, and I've been on the same one ever since.
And since then, how have things been?
It has been a complete 180 since those times. Really, one of the most life-altering things I've ever experienced. And such a blessing, I don't know, remembering those times. There was a distinct time where really we were unsure if I would ever even make it back to high school. And now being a student at Auburn University, finishing up my sophomore year, and I'm going to begin nursing school in the fall, it's really just, I'm incredibly thankful for that diagnosis. It really changed my life.
Yeah, you're definitely a success story, and it's amazing the correct diagnosis and the appropriate treatment, and it really has enabled you to get back to life, which is what we aim for. Other than the fogginess and the sleepiness, did you ever have any symptoms of something called cataplexy?
I did, and looking back, that's one of the things that was never very noticeable to me. Once the narcolepsy was diagnosed and the symptoms were very well controlled, I kind of looked back over my life and, learning more about the disorder in general, was able to pinpoint things like mild cataplexy, which kind of felt like, for me, like when I would cry or laugh particularly, kind of a sudden loss of muscle tone, almost a feeling like dizziness and weakness, like my knees were going to fall out from under me. And so things like that, and that is definitely one of the symptoms that I kind of just became used to over the years. I didn't even know was abnormal, but something that changed once the narcolepsy was well controlled under medication.
Is the cataplexy something, Lori, that y'all noticed as well?
No. It's been fascinating to hear Heather's retrospective, her perspectives looking back. I asked her, but one of the things that's interesting, we were talking earlier that I've become fascinated by our adaptive behaviors. And one of the things that her friends and teachers would note is that Heather's very stoic. And we even talked about, I think maybe you began to adapt and became a little stoic because you began to realize if my emotions sway too far to the left or right, I'm going to start feeling weak, and that almost she developed a little bit of her stoicism to avoid that.
Mm-hmm. Once you were getting the appropriate treatment, has the cataplexy resolved as well?
It has, yeah. Very remarkable.
Have you noticed any change in that stoicism?
Well, and I think two things. One is she's more comfortable in her own skin. It's really tough when he's like, something's wrong. And like I said, I don't even know how to answer and say why I'm not in school. Mm-hmm. So part of it is being more comfortable in her own skin, understanding herself better. She's less guarded with her relationships, but also, I think having that under control. And the other thing that I had noticed, my husband and I had noticed, even from an early age, was the restlessness during sleep. You said now you sleep all night perfectly, because she didn't sleep well at night, and it wasn't because she was up like on the computer or watching TV. It just, she had fragmented sleep, but that's improved too, right? Mm-hmm. Mm-hmm.
And earlier you were talking that Heather had poor sleep even when she was very young. When do you think she first started having any symptoms of narcolepsy?
I wish I knew. It's a fascinating question. It definitely, even I believe, predated 6th grade when I first started saying, could there be a sleep disorder? I'd say in her toddler years. Again, one of the biggest secondary conditions or comorbid conditions that threw us off track was the asthma. And certainly some of the time when she was having an asthma exacerbation and she would wake up coughing, obviously, well, we got to get this under control to know how much sleep restlessness is left. But I would not at all be surprised if it began in her toddler years.
Okay. Well, thank y'all for sharing part of your journey. I promise we'll get back and have some other questions to ask you guys at the end. And for anybody watching, if you have questions for them too, just kind of save them and let us know. We're going to kind of delve into some of the science and the treatments behind narcolepsy. So before we do that, though, I think a little bit about normal sleep. Sleep is something that many of us in the pediatric field don't get exposed to a lot, so just 2 slides on normal sleep. This is a hypnogram, which is a graphical depiction of the different stages of sleep that we go through. We start with wake, and before you fall asleep, you get into N1 sleep, which is really light sleep. It's the kind of sleep that if you've ever been up all night and driven home and then don't really remember how you got there, that was the kind of sleep you were probably in and out of as you drove, which is pretty terrifying. But the second is N2 sleep, and that's the kind of sleep that most adults get most of the time. That's the sleep where you're deep asleep, you are getting that rest, but it's not as deep as you'll get later in the night. Stage 3 sleep is also known as slow wave sleep, and that's the kind of sleep that children get much more than adults. That type of sleep wanes as we get older, and so elderly people do not have N3 sleep generally, or very little, as opposed to kids where half their night is spent in that slow wave sleep. It's the really deep sleep where you see kids falling asleep in chairs or on the floor or anywhere and can sleep through anything. It's also the stage of sleep where growth hormone is secreted. The last stage of sleep is REM, and that's the darker bars on the hypnogram. And REM is the sleep where we dream, where we have various attributes of the sleep study, which I'll talk about in a second, that helps define REM. You can see from the hypnogram, most of our REM is in the second half of the night, and the slow wave sleep tends to occur in the early parts of the night. So this is 2 kind of graphical depictions of what you'd see on a sleep study. The first one, the top one, is that N2 sleep. This is a person that we've recorded, and the first bar there is EEG leads, the first 2. And that shows a normal EEG pattern for somebody in N2 sleep. That sharp spike there is called a K complex, and there's some sleep spindles scattered throughout there too. That's a normal finding of that type of sleep. The thing to draw your eye to is the third line down, which is the E2 lead. That's an eye lead that shows eye movements, which are small and irregular there. And the last one is the chin tone. That thick bar means there is muscles that are contracting during that type of sleep. The one below it is from REM. And the differences here are pretty important. The first two leads are, again, that's the EEG leads. And you can see it's more of a sawtooth pattern. It's not as dense as that N2 sleep. The eye leads have those really sharp, high amplitude peaks, and that's rapid eye movements. That's one of the things that defines REM. The other, as you can see, the chin tone is much diminished, and that's one of the other key features of REM, is that you get a skeletal muscle atonia. So basically muscle paralysis of almost everything except for those eye movements and your diaphragm. In addition to REM sleep, that's also when you dream. So those are the four characteristics of dream sleep or REM sleep that are really important to narcolepsy. Rapid eye movement, muscle atonia, that EEG pattern, not abnormality, and then dreaming. So narcolepsy is a lifelong condition of excessive daytime sleepiness. It may or may not be accompanied with cataplexy, which is this loss of muscle tone when awake that's usually triggered by strong emotion. The graphical depiction there, that scale, though, is a good way to think about it. Because with narcolepsy, your scale's out of balance. You're starting to get dream sleep kind of overwhelming your daytime wakefulness. So you're getting dream sleep that's pushing into daily life. And that's really what narcolepsy is. It was first described by Gelanu in 1880, and he described it as narcolepsy. He described a few patients with brief recurrent attacks of sleepiness throughout the day, even though they'd had good nights of sleep. He also reported that many of these patients had frequent falls, which he called atasias. And he collected a collection of patients that he followed back in the 1880s. Later on, in the 1930s, another physician named Daniels described the clinical constellation of what we really identify as narcolepsy with cataplexy now, and he had a tetrad of symptoms, which are daytime sleepiness, cataplexy, hypnagogic hallucinations, as well as sleep paralysis. And all of those we'll talk more about in just a minute. Before we delve into that, though, the incidence of how common is this, or why should a general practitioner somewhere out in the community pay much attention to this disease? And the incidence is more than what anyone really thought. We know that daytime sleepiness occurs in up to 20% of children and adults. And usually that's related to either not enough hours spent asleep, poor sleep hygiene, other issues, and it's not narcolepsy. The first real epidemiologic study about narcolepsy was done and published in the late 90s, and it was done in a county called Olmsted County in Minnesota, and that's what's highlighted on the map, because I did not know where Olmsted County, Minnesota was, so I went and found it. And what they did is they looked at a huge data set to try to figure out how often does narcolepsy occur. What they found was that it occurred in about 1.37 per 100,000 persons, but the prevalence was about 56 per 100,000. So it's not as rare as they expected it to be. There was a slight gender bias with more men than women in that study, although other studies have not shown such a profound difference in the genders. The prevalence is most common in Japan, in studies done there, where the prevalence is 1 in 600, and compared to Israel studies, where it's 1 in 500,000. We estimate, based on a few studies, that the childhood prevalence was about 20 per 60 per 100,000 in the United States. And we are not diagnosing that many patients with narcolepsy to date. So the age typically presents in middle to late adolescence. It's usually post-pubertal before people really get diagnosed with this, with the median age being about 14.7 years. A third of patients, though, if you ask them, say they started having symptoms before they were 15, 15% of patients report that they had the symptoms before they're 10, and almost 5% of patients had symptoms prior to 5 years of age, which is pretty amazing because often 5-year-olds are still napping in the day, so there's not a strong clue that pediatricians or other healthcare providers can really link onto. But it's important to listen to families and patients because they are trying to tell you what's going on. But this really points to the issue that there's a huge lag time between when the symptoms first start, like with Heather's symptoms, and before when the diagnosis is made. On average, it's between 5 and 15 years, which if this is a disease that starts during your childhood, those are 5 to 15 years of development, of educational attainment that you may be at risk for not getting because you're falling asleep or having other symptoms associated with narcolepsy, which can really impair your ability to have a meaningful and full life. One of the really interesting things about epidemiology was some data that came out of China in the late 2000s and early 2010s, where they found there was some significant seasonal variation in the diagnosis and incidence of narcolepsy. They found the highest numbers in April and the lowest in November. They didn't really have a good reason to explain that yet. They also found with the H1N1 flu pandemic back in 2009, there was a 3-fold increase in diagnosis of narcolepsy after patients had had that illness. So it led to the idea that perhaps there's an immune-modulated portion of why narcolepsy occurs, although a lot of the work and research and science is still trying to elucidate exactly how that link occurs. So in families, though, narcolepsy tends to be sporadic. You don't tend to have large family clusters with lots of narcolepsy, although we do know that first-degree relatives of patients with narcolepsy have an increased risk of about 1 to 2% of having narcolepsy, which is about a 10-fold up to 40-fold increase from the general population. When it comes to narcolepsy, though, beyond the medical and the symptoms that we're going to talk a lot more about in just a few minutes, there are some significant financial burdens that people with narcolepsy have faced. Compared to controls, in a few studies, we've seen that narcolepsy subjects had a 2-fold higher number of annual inpatient hospital admissions. They visited the ER twice as frequently. They went to outpatient clinic twice as often as patients without narcolepsy and had double the number of physician visits. And those are not all related to the management of their narcolepsy, but often it's patients who are trying to figure out what was going on. And once the diagnosis was made, the number of visits tends to trend toward normal if patients are under therapy. The other interesting kind of finding from this study was the amount of money spent on pharmaceuticals for patients with narcolepsy versus not. They found that the annual number of drug transactions, so the number of times the patient picks up a prescription at the pharmacy, was double compared to people without narcolepsy. The next number, that 337% higher use of narcolepsy drugs, that to me was not shocking. You would hope people without narcolepsy are not on narcolepsy drugs. But the other number is, I thought, was important, and that 72% of patients with narcolepsy, they're filling 72% more non-narcolepsy medications than patients who don't have narcolepsy. And so you can see the total cost for a patient with narcolepsy was about $8,000 compared to $4,000 for someone without. And almost all of that difference was driven by the drug cost, about $2,000 on narcolepsy medications. So it's an expensive disease, but it has huge impacts on the patient's quality of life. So there are 2 forms of narcolepsy that we've already touched a little bit upon. The first is type 1, also known as narcolepsy with cataplexy. Narcolepsy with cataplexy has excessive daytime sleepiness, hallucinations when you're falling asleep or waking up from sleep, sleep paralysis, fragmented nighttime sleep, and then cataplexy, and a loss of something called orexin, which we'll talk more about in a moment. Type 2 narcolepsy, or narcolepsy without cataplexy, is the same symptom constellation: excessive daytime sleepiness, the hallucinations, sleep paralysis, and fragmented nighttime sleep, but you don't have the cataplexy, hence the name. So there's 4 central things: excessive daytime sleepiness, cataplexy, the hallucinations, and sleep paralysis all go back to what is REM. And so excessive daytime sleepiness, that's REM sleep intruding into your wake time. Cataplexy is muscle atonia, that loss of chin tone that you're seeing across all of the different limbs and skeletal muscle. That's why cataplexy happens. The hallucinations is dreams interfering into your wake state, and sleep paralysis is the muscle atonia as well. So all 4 of these main key pillars of what is narcolepsy directly relate back to this is just an intrusion of REM sleep into wake. So we're going to walk through each of the different 4 components of narcolepsy and really drill down to what they are and how it impacts the pediatric patient. So the excessive daytime sleepiness is really the most common symptom of narcolepsy. It's seen in approximately 100% of patients with narcolepsy. And it's really the chief complaint that pediatric patients or their parents express when they come to clinic to try to figure out what's going on. And this is just the overwhelming urge to fall asleep that worsens in situations with low stimulation, but can occur anywhere. So it's not infrequent to have a patient describe to us that they fall asleep certainly in a class that may be boring, certainly after lunch when normally people feel more sleepy. We also hear patients saying, well, I fell asleep in the car while I was riding as a passenger, or when I was driving, or I fall asleep at the movie theater. I fall asleep even talking to some of my friends. And those are situations where you would not expect a normal, average patient and teenager without narcolepsy to be falling asleep. And it can be really disruptive. This daytime sleepiness occurs despite adequate nocturnal sleep. So these patients are getting enough sleep at night. They may, throughout the day, have frequent micro-sleeps, and so that may manifest as just a very quick power nap of 5 or 10 minutes, or maybe even faster, a 30-second nodding off in class that the teacher may say, oh, they just didn't sleep last night, or they're not paying attention. Sometimes these daytime sleeps are accompanied by some autonomic behaviors like muscle twitches or facial twitching, and those can sometimes really force people toward more looking at seizures and other diagnosis to try to explain this. And often children get labeled as lazy, and so that's a frequent complaint in the sleep clinics of patients with narcolepsy. Well, their parents or their teachers will say, well, they were just lazy. They're just falling asleep all day and not doing anything. And in fact, this is how the disease manifests. The second kind of important symptom constellation is cataplexy. This is the second most common symptom in pediatric narcolepsy. It's the sudden loss of muscle tone in the facial muscles, particularly, or the thighs, back, and neck. It's usually, like with Heather, a response to strong emotion. So being scared, being really angry, being excited or laughing, or being surprised. So we'll often ask patients in clinic, I have a weird question for you. Do you ever go and watch scary movies, or do you ever go to a football game and cheer? And most people have done one of those two things. And when you ask, well, does anything weird happen to you when something important or scary happens either on the movie or something exciting happens at the game? And often people say, well, I feel like I get weak or my jaw will open. And often the patient may notice it, and sometimes parents won't, similar to what we heard a minute ago. And sometimes it's the inverse, where the patient may not realize it until others bring it to their attention. And so that's a question that we often ask. And this is, again, that intrusion of the muscle atonia from REM into the wake state. The pictures are here from a study in 2008, and this is just 6 different patients who are having episodes of cataplexy there. And you can see there's the one on the upper far right there has the grimacing. It almost looks like a tic. The other is just a loss of muscle tone with eyes opening or their mouth opening, and they can't control it. So cataplexy is caused by the hyperpolarization of the spinal alpha motor neurons. And these are the long nerves in your back that help control your skeletal muscle. And when they get hyperpolarized, it inhibits your ability to control those muscles. And so you get a sudden suppression of muscle strength and contraction, and your tendon reflexes aren't there. So I think we'll have a video here in just a second to show you one person who has cataplexy and posted her episode of cataplexy on the internet. We've edited a little bit for time purposes, but hopefully you'll be able to see that in just a second. And so there you can see the patient. She is doing a dance routine, and all of a sudden she just lost the muscle tone in her legs. So she collapsed to the ground, and then in a second she has another attack of the cataplexy, and she lost the upper extremity tone as well. And so that's a pretty very obvious example of muscle atonia, and that's not typical. Usually people have more subtle findings with the jaw just slumping open, or maybe their head dropping down, although certainly, like what you just witnessed, is very much a way that this may present. The third symptom of narcolepsy is the hallucinations. And We divide the hallucinations into two categories. There's the hypnagogic hallucinations versus the hypnopompic. Hypnagogic are the hallucinations which occur when you're falling asleep, as opposed to hypnopompic, which is when you wake up from sleep. And this is that dream sleep that persists even when you're awake. This occurs in about half of patients with pediatric narcolepsy, but if you have these symptoms yourself, don't get concerned. It's a fairly common finding in patients who don't have narcolepsy as well. So about a quarter of adults who don't have narcolepsy will have hallucinations. Typically, they are generally when you're falling asleep as opposed to waking up. And then 18% of pediatric patients may also have these as well. And then 18% of adults will have the hallucinations when they're arising from sleep as well. So that's not a very good test to discriminate narcolepsy versus not having narcolepsy, but it is a finding we frequently will see. Sleep paralysis. This is the momentary inability to move or speak that occurs either with sleep onset or offset. It may be accompanied by eye fluttering, by moaning, or other autonomic symptoms, and it tends to end spontaneously or if someone touches you. And this can happen frequently. Up to 80% of patients, adult patients with narcolepsy, report having this, about half of pediatric patients, and it occurs in about 3 to 5% of the general population. When you ask patients who have had sleep paralysis what this is like, almost to a person, they say it's the scariest thing I've ever experienced because they feel like they're trapped and can't move where they were laying in bed. And so that's a pretty good clue. If someone says that, they probably had sleep paralysis. The other really key finding in narcolepsy is a really disturbed nocturnal sleep architecture. So we know that people who have narcolepsy, their sleep is very fragmented. They wake themselves up very frequently throughout the night, and they get into REM sleep very quickly when they're first falling asleep. And so looking at lots of sleep studies over time, we've noticed that you have a very fragmented sleep architecture. If you compare that original hypnogram we looked at, where we had a very nice progression of the different sleep stages, this is actually patient data. The upper one is a patient without narcolepsy. You can see the pink bar here is the REM. REM sleep tends to be at the latter half of their night. And then the lower one is the patient with narcolepsy. And you can see they get into REM sleep within about 5 minutes of going to sleep, and they wake up within about 20 minutes of falling asleep. And the rest of the night proceeds that way, falling asleep rapidly, waking up rapidly, and going into REM throughout the night, and no real long periods of sustained sleep. And so that's one of the reasons patients with narcolepsy are always tired, is they're not sleeping well during the night. And I've mentioned this a few times, but there are other symptoms. There's autonomic behaviors which occur, like frequent staring spells. Often patients get evaluated for partial epilepsy or absence seizures. People often will get mislabeled as having ADHD when in fact they have narcolepsy as well. And repetitive behaviors like lip smacking, picking at nails or skin tends to be pretty common as well. We do know there's an increased risk of other mood disorders in patients with narcolepsy, so there's an increased risk of anxiety, depression. I was very focused on academic performance. I listed it twice on this one, that you have impaired academic performance and decreased academic performance. You also find an increased amount of headaches, although it's less than about 15%. And precocious puberty is a frequent finding in patients with narcolepsy, with about 17% of pediatric patients having precocious puberty. The other kind of factor that is frequently seen in patients with the onset of narcolepsy is obesity. It's found in up to 50 to 74% of pediatric patients. There was a study in 2013 where they documented 50% of patients with narcolepsy had a Z-score, a BMI Z-score of greater than 2. And there's lots of reasons why this might be. The first is there is a loss of normal nocturnal leptin rise, and leptin's a hormone which is an appetite suppressant, and so the loss of that leptin release does tend to cause weight gain. In addition, the loss of leptin and loss of other neurologic function may cause a decrease in the basal metabolic rate, so people tend to gain weight when that happens. So there was a study in New England Journal published in 2015 where they documented patients tended to gain between 20 and 40 pounds at the onset of narcolepsy. although when the onset of narcolepsy is sometimes hard to define. So with more local data, this is information for patients seen in the Sleep Disorder Center at Children's, a retrospective review done by Valerie Tarn, one of our nutritionists and dietitians. And so she looked at 21 patients who had narcolepsy between the ages of 4 and 18 at their initial presentation. And what they found was the mean BMI percentage was 82.6%, and really only 28.6% of the patients were normal weight at diagnosis. And you can see the breakdown there of the different weight categories. But really over half of our patients with narcolepsy were either overweight or obese when they were reviewed at onset of the disease. So it's a problem here, and it's a problem nationally as well. So, but what is narcolepsy? Why does this happen? And so the pathophysiology of the disease. So we knew early on that there was an association between the histocompatibility leukocyte antigen receptors of specific types and the development of narcolepsy. Originally, there's the HLA-DR2 that people thought this may be the reason that narcolepsy occurs, but they found that that was a very frequent mutation there, and lots of people had it who did not have narcolepsy. So further studies found there were two other antigen complexes which seem to have a higher correlation with the development of narcolepsy, and those are HLA-DQB1-0602 and HLA-DQA*0102, and those two have a much tighter linkage. They're found in close to 95 to 100% of patients who have narcolepsy. There's still a big portion of the general population, up to almost 40%, who have those as well. And one of the two is linked to shorter REM latency, which means you fall into sleep, you get into REM quicker, an increased sleep efficiency, and decreased N1 sleep, which is that really not good sleep. So that one may have some benefit for your overall health, and that's a histocompatibility complex which really mediates good sleep. However, if it goes wrong, that's where you end up in narcolepsy. The second piece to the narcolepsy puzzle was really discovered in canine models that had narcolepsy. And so what was found there were in Dobermans who had narcolepsy, a protein called hypocretin, which was found in the dorsolateral hypothalamus and spread throughout lots of the brain, that really projected to places that were the awake stimulating portions of the brain. And so what they found there was these dogs had less receptors for hypocretin, which is also known as orexin. And so that was discovered in the late 90s and early 2000s. And so we'll have another video. This will be a clip of one of the Dobermans with narcolepsy with cataplexy. So hopefully y'all can see that in just a moment. And so the dog is there playing. He's about to give the dog a treat. The dog gets excited with the treat and loses muscle tone. And so that happens whenever they feed the dog or whenever the dog gets excited. When they say, let's go out for a walk, the dog gets excited and he falls over. And so it happens again and again. And so they had a really good animal model to try to figure out what was going on in patients with narcolepsy. And they discovered, like I said, that there was a decline in the hypocretin receptor density in a particular part of the brain. So in humans, we don't see that same thing. We don't have a decline in the hypocretin or orexin receptor density. What we find in patients with narcolepsy with cataplexy is, in fact, there's a decrease in the amount of orexin that is secreted in the spinal fluid. And orexin is generated in the hypothalamus, and you can see on the image there, it has projections throughout the brain and brainstem, which really increases your metabolic rate, your arousal, and it really keeps you awake. And so the absence of that compound has the inverse, in that people are more likely to fall asleep and more likely for dream sleep to occur while you're awake. So what we know is that narcolepsy with cataplexy is linked to low levels of this hypocretin-1, which is also known as orexin. Neurons in the hypothalamus have these widespread projections, but they don't have that chemical to fire appropriately. And so we know that a decrease in the amount of this hormone strongly correlates with having narcolepsy with cataplexy. And the absence of this hormone leads to a downregulation of various other pathways in the brain, as well as brainstem, which really regulate your REM. And so this absence or decline in hypocretin leads to a cascade that ultimately results in the clinical findings of narcolepsy. But how do we put those two things together? And so we know that there's a good portion of the population that has these HLA kind of variations, but not everybody that has those histocompatibility complexes have narcolepsy, and why. So there was a really interesting family study where there was a pair of twins who they both had the mutation, the HLA DQB star 0602. One of them developed narcolepsy at 12. The other didn't. And so they followed both of these twins for decades. At the age of 44, the twin who did not have narcolepsy had a very emotionally stressful time and a period of sleep deprivation. And when that occurred, she developed narcolepsy. And ever since, she's had narcolepsy as well, which leads to this two-hit hypothesis that people have a genetic predisposition, the HLA mutation perhaps, and then they have a second event, a stressful event or something else that precipitates their body to respond and develop narcolepsy. Whether that's due to an autoimmune process or some other etiology, we don't yet know. But this is beginning to see the linkage between the genes and the environment, which leads to the development of this disease. And so it's really cool science that we're still working on figuring out. And this is just a schematic again. These are some of the projections of where orexin is in the brainstem and where it connects to the locus coeruleus, the PPT and LDT, and the other different aspects of the central nervous system kind of control centers. And so all these different pieces that are labeled are the parts of your brain which are the arousal cortex, the parts that keep you awake. The basal forebrain, the cortex, this is how you stay awake. And when orexin turns off, they don't get the stimulation they need to keep us awake and to keep REM from occurring. So that's kind of what narcolepsy is and how it occurs, like what are the symptoms, what are the science, the alterations in the brain that lead to narcolepsy, or at least our understanding of it to this point. But for those of us who are clinicians, we need to know, well, how do we figure this out in our patients, and how do we help them manage this disease, which is altering their life? And so we're going to talk about the history and physical. We're going to talk about some standardized scales and instruments and tests, and then the diagnostic testing to ultimately figure out what's going on. So as with any medical problem, medical history is important. And so you need to do a routine history and physical exam. In particular, though, you need to focus on other causes of sleepiness. So assess in the history for head trauma. So certainly concussions or other injuries to the head can cause sleepiness. Additionally, if there's any neurologic abnormalities, so brain tumors can also cause daytime sleepiness. Those don't need to be missed. So that needs to be assessed when you're thinking about patients who are sleepy during the day. A family history of diseases is important. If family members have a history of CNS tumors or other kind of etiologies or any abnormalities in the metabolic system, those are things that also would be helpful to find out on a history and maybe lead you to a path that isn't going to lead in narcolepsy. Behavioral assessment's important. Sometimes patients may come to sleep clinic and their complaint is sleepiness, but they also have had other abnormalities in their development. Perhaps they have a neuromuscular disease or maybe an inborn error of metabolism. These are things that need to be assessed, like was the patient developing normally and then all of a sudden started having sleepiness, as opposed to was the patient always developing on a different trajectory than the average child and they also have sleepiness. So there are two different kind of categories to look down. And then making sure you're asking the questions, well, how old was the patient when the patient walked or talked or sat up? And trying to, again, put this disease in the constellation of the other findings that you see in a clinic visit. In addition to the normal medical history, though, you need to talk about a sleep history. And sleep histories are notoriously difficult to obtain in that they take time. And so for busy clinicians, it's often hard to sit down and really have a long discussion about sleep problems when you don't have a framework to really walk through. So two researchers and sleep physicians, Jody Mendel and Judy Owens, they created or put together this concept of the Bears questions. And so you can see from this slide, each of those bullet points, B, bedtime problems is the B, excessive daytime sleepiness E, and the first letter of each word spells bears. And that's a good way to try to remember this mnemonic. So asking about bedtime problems. So do you have any trouble falling asleep? Do you have trouble when you lay down in the bed and trying to get to sleep? Do you wake up frequently? Like, tell me about when you're first going to bed and the times you go to bed. The E is excessive daytime sleepiness, and that's an easy question. Do you fall asleep during the day or at times you don't want to? Most people will say no if they're not having any sleep issues. Asking the A is awakenings during the night. Do you wake up frequently during the night? Do you have to go to the bathroom during the night? Do you wake for other reasons? The R is the most challenging, I think, of all the questions for the Bears, and that is the regularity and duration of sleep. So, but that's asking, well, what time do you go to bed? What time do you wake up? Do you wake up about the same time every day? Do you have a different bedtime during the weekdays versus weekends? But it's really getting to that level of detail for a sleep history. And then the last for Bears is S, or snoring. And so that's generally one where you have to ask not just the patient, but their parent or anybody else who may be sleeping in the room. It's a very frequent occurrence when a patient's sibling who's in the exam room will say, oh, my brother or sister, they snore so loud I can't sleep. So the sibling doesn't have the sleep problem. Well, they do, but it's caused by the patient who's snoring. So this is a really good framework or a mnemonic, the Bears questions to ask to get a good handle on what the person's sleep is like. Another evaluation tool that can be very helpful in evaluating a person who comes to clinic with daytime sleepiness is a tool called a sleep diary, and it's exactly what you think it is. It's a piece of paper that has the dates and then each day broken into the time. And so this doesn't project real well, but this is a sleep diary of a patient, and each one of the rows is a different day, and it starts at midnight on the left and goes all the way till 11 p.m. on the right. And what you ask the patient to do is to color in when they're asleep and to put a letter B when they get into bed. And so on this example, you can see the little dots on the far right of this picture are when the patient gets in bed, which is, it looks to be around 11 o'clock. But the patient wasn't actually falling asleep until about 1:30 or 2 every morning, and then they'll wake up to go to school at 6. And so they were trying to figure out why they were sleepy during the day. So you can quickly show them, well, you only sleep 3 hours a day. You're taking naps scattered throughout the school, which are those little isolated blue bars. And then on the weekends, you have a long recovery phase of sleep. And so when you have this kind of graphical depiction to walk through with a patient and parent, it quickly can make sense of what they perceive to be a sleep problem, when in fact it's really a sleep scheduling issue. There are a few formal sleepiness scales that have been developed. Most of them are created for research purposes and then have been modified to be used in clinical situations. The first one, the one that's most common, is the Epworth Modified Sleepiness Scale, which is a questionnaire of 8 different scenarios, and you ask the patient to fill it out asking how likely would you be to fall asleep in each of the following scenarios. And it goes from very likely, like how easily would you be able to fall asleep sitting quietly in a dark room after a big lunch without any alcohol, and most people could fall asleep in that situation, versus how likely would you be able to fall asleep while talking to a friend. And so you score this from a score of 0, which means you're not sleepy at all, to 24 means you'd fall asleep in all these scenarios. And so that's a really common assessment that's used. We use it in our sleep clinic. There's also 2 others, the Pediatric Daytime Sleepiness Scale. It's a little bit more complex and takes more time. And the Cleveland Adolescent Sleepiness Scale, which again has more questions and is a little more time intensive. But those are all good tools you can use in your clinic to help figure out how sleepy a person is and to give you a number that you can look at and say, oh, how are we doing, especially once you start treatment. So, but ultimately, the diagnosis for narcolepsy is dependent upon a sleep study and something called an MSLT. So the sleep study, also known as a nocturnal polysomnography, or NPSG, and the MSLT is the mean sleep latency test. And what these are tests you come to a sleep lab, and the patient is monitored. Their EEG, their EKG, their eye movements, their chin tone, their limb movements, their respiratory patterns are all monitored as an overnight sleep study. And one of the reasons you do a sleep study for the diagnosis of narcolepsy is you want to rule out other problems to make sure the patient doesn't have undiagnosed obstructive sleep apnea or undiagnosed periodic limb movements of sleep, and to prove they had a good night's sleep. And so after you've done the sleep study, the next day you would do an MSLT or a NAP study. And the MSLT is 5 different periods of 20 minutes where you ask the person to try to fall asleep. Every 2 hours, they get 20 minutes in a cool, dark room to try to fall asleep. And most people, well, I'll show you what the data in a second. Most people can't fall asleep that quickly after a good night's sleep. But the mean sleep latency study is the diagnostic gold standard for diagnosing narcolepsy. So we have norms in the adult population where the normal MSLT is about 11 or 12 minutes, whereas patients with narcolepsy, they tend to be able to fall asleep within 3 minutes. And they tend to be able to drop into REM sleep on at least 2 of the 5 nap periods. Patients without narcolepsy, they don't do that. So, but the MSLT was not developed, and we don't have norms for younger patients. So a paper published in 1982 looked at the way that the MSLT varies with Tanner stage, which Tanner stage is a developmental assessment of puberty, essentially. And so stage 1, you've not yet hit puberty, and as you walk through the different Tanner stages, you move to adult physiology. And you can see that the mean sleep latency for children is 18.8 minutes and drops to 15.8 for the older adolescents, whereas the adults, back on the last slide, the average was 11.6 minutes. So we get it's easier for us to fall asleep as we get older. So the MSLT helps us to diagnose narcolepsy, and that is what we do to diagnose narcolepsy. If patients it's unclear if the patient has narcolepsy, and the MSLT, maybe it's a really young patient we don't have a norm for, you can assess the cerebral spinal fluid hypocretin level. It's not a test that's available in the average lab. There are a few places that do this as a research basis, and they can be reached out to send samples to, and they'll run it for you. But the levels are low in patients with narcolepsy with cataplexy. In patients with narcolepsy without cataplexy, orexin or hypocretin levels tend to be normal. So the differential diagnosis for narcolepsy is broad, and we're not going to go through all of these, but there are a few that I think we need to highlight, and those are the ones that are bold. The first one is the most common reason patients come to sleep clinic and they're sleepy and that they're not getting enough sleep. An average teenager should get closer to 8.5 or 9 hours of sleep. Most teenagers get between 6.5 and 7 if we're lucky. And so that's the most common reason patients may be sleepy in clinic. And one of the reasons that is this 24/7 lifestyle that has developed. This was a study from a couple of years ago looking at 100 adolescents in Philadelphia who had a median household income of $53,000. And what they found was that 2/3 of these teenagers had a TV in their bedroom, 90% had a cell phone in their bedroom, and 79% had a music player. Almost all of them were engaging in at least 4 electronic activities after 9 p.m., and most of them were reporting they were sleeping less than 8 hours, with 1/3 saying they fell asleep at school. The other aspect of this is we have really poor sleep hygiene. We as a society use a lot of stimulants, caffeine being the chief one, and ADHD medications are widespread. Both of those really inhibit your ability to sleep well. And so that same study from Philadelphia, they reported that 85% of patients reported drinking caffeine of at least 144 milligrams every day. And most people are using their bed and bedroom for activities other than sleep. So doing their homework, working on schoolwork, organizing for clubs and activities, being on social media, things that are stimulating and not conducive to sleep. So really your bed and bedroom should really only be used for sleep. And that focuses in with poor sleep habits. A lot of patients and others spend a lot of time in bed but not asleep. So watching TV, napping throughout the day, And so they're not conditioning their brain to associate their bed and bedroom with this is where we sleep. There's also a lot of exposure to LEDs and blue screens. And so we know that this wavelength of light, that blue color, hits the back of our retinas and causes us to have a surge in our cortisol level, which is the hormone saying it's time to wake up. So we are actively putting ourselves in this blue light right before bed. So it makes it hard for our brains to realize it's bedtime, it's nighttime. And so that is another reason people struggle to fall asleep well. The next one is the circadian rhythm disorders. So at the top of this is a person with a normal sleep-wake rhythm. They tend to go to bed around 10 o'clock. They wake up most mornings between 6 and 7, and that's a normal pattern. Teenagers, though, they shift, and so their sleep pattern tends to delay. And so rather than wanting to be in bed from 10 p.m. until 6 a.m., they want to go to bed at midnight or 2 a.m. and sleep until noon. And this is a normal physiologic change. The problem is our society doesn't work on that schedule. So school still starts at 8 o'clock, but we're working to shift that to help accommodate the physiology. But often patients will come to clinic. They're sleepy because they can't fall asleep till 2. They're having to wake up at 5 or 6 to go to school, and they're only getting 4 or 5 hours of sleep. So it's no shock that they're tired. Klein-Levin syndrome is a really rare disease of hypersomnolence or excessive sleepiness. It occurs in adolescence. The incidence is about 1 in a million. It tends to be male more than female, and this is a disease where a patient will have a period where they will fall asleep or sleep for 16 to 20 hours a day for several days in a row, up to 2 or 3 months, and then they'll have a period of normality, and then it'll happen again. But this excessive sleepiness is also accompanied by excessive hunger and hypersexual behavior. And so it's a really rare disease. If you have a patient who meets those kind of criteria, they're probably someone that needs further evaluation at a sleep specialist. And last is idiopathic hypersomnolence. So these are patients who have daytime sleepiness. They have had a sleep study that's normal, a mean sleep latency test, which shows they fall asleep quickly, but they don't have those REM onsets. They don't meet criteria for narcolepsy. They often will have sleep drunkenness, where they'll be very confused when they wake up from either naps or from the nighttime sleep. And one of the things that helps distinguish often idiopathic hypersomnolence from narcolepsy is patients with narcolepsy after a 15-minute nap, they tend to be refreshed. Patients with hypersomnolence after 15 minutes, they're confused and angry. And so that's one of the distinctions often between those two conditions. So the actual diagnosis of narcolepsy type 1 is a period of irrepressible need to sleep that has been occurring for at least 3 months in the presence of one or both of the following: that MSLT less than 8 minutes and 2 sleep onset REMs, and a CSF hypocretin concentration which is low. For type 2 narcolepsy, it's very similar, with the difference being the hypocretin measurement is either not done or is normal. And so that's the distinction on the official ICSD, which is the International Classifications of Sleep Disorder, the way you diagnose these diseases. So now onto the treatment and management of narcolepsy. The first thing is the creation of an individualized treatment plan, which may encompass both education for healthy sleep habits, behavioral changes, medications, and other aspects like IEPs or 504 plans. So the education aspect. So this is important. When you make a diagnosis of narcolepsy, it's important to spend some time talking with the patients, with the patient's family, with the friends, with anybody that they feel needs to know more about narcolepsy. Sometimes this will involve phone calls or face-to-face conversations or electronically with coaches and teachers who may not have ever heard of narcolepsy before and are very confused about what the plan is as you talk about what needs to be done at school. Often patients and parents do need to notify their school officials to let them know about the diagnosis and to seek appropriate accommodations with either 504 plans or an IEP. We stress the importance of good sleep hygiene and good sleep schedule. It's critically important for patients with narcolepsy to make sure they're getting enough sleep at night so that they're getting the number of hours necessary for them to function during the day. Talking with Heather and her mom earlier, she mentioned this too, that it's really important for her to keep a set awake time. And that's hard, especially if you're a high school or college student when schedules tend to be more fluid. But setting that wake time that you try to keep to both weekdays and weekends is hard, but really important for patients with narcolepsy. Like I mentioned, these short power naps are very important. So often scheduling a nap in the morning and a nap in the afternoon at school can help lessen the sleep pressure and lessen the daytime sleepiness so the person can function much more effectively. And really stressing the importance that the bed should be only for sleep. Don't do your homework there. Don't have arguments with your significant other, boyfriend, girlfriend, or anyone else, either on the phone or social media in your bed, but keep it for a place for relaxation and really limiting the screen time. Behavioral changes, this is hard, is limit caffeine use. So often adolescents who have narcolepsy have been self-medicating with caffeine for perhaps years trying to stay awake and trying to limit their caffeine use, particularly right before bedtime, to try to help them get good sleep. Alcohol is illegal for patients under 21, but regardless, we know that patients may choose to drink alcohol, and really encouraging them to not drink alcohol as it can worsen your sleep in general. Exercise has also been found to be important in the treatment of narcolepsy because it tends to help promote some of those alert compounds in the brain and may help to counteract both the sleepiness and the weight gain that patients have with narcolepsy. And the nicotine also fragments sleep and is a stimulant, so we recommend stopping smoking if they are. There are certain activities which tend to be dangerous in a daily life for patients with narcolepsy, and the three that really get the most attention are cooking, swimming, and driving. So patients who have narcolepsy who aren't being treated need to be careful when cooking so they don't cause a fire. Swimming, for obvious reasons, you don't want to be swimming and get excited and have a cataplexy event and then drown. And then driving has a whole different group of issues we'll talk about. So there have been several studies looking at driving in patients with narcolepsy. There was one in 2015 in France where they looked at patients with narcolepsy and they were measuring their Epworth sleepiness scale. And what they found is that patients with narcolepsy had a very similar rate of car accidents to patients who were healthy compared to narcolepsy patients who were treated. But for patients who were not treated, they had an increased risk of accident. There have been a couple of studies. This was one from 1981 in Canada where they looked at narcolepsy in actual car accidents and tried to compare it to controls. And what they found is that patients with narcolepsy reported falling asleep while driving 66% of the time, compared to the general population, which 6.2% of the population says they do that. So almost 30% of patients had an event of cataplexy while they drove, 11% had paralysis of sleep paralysis while they drove, 2/3 had a frequent near accident, 1/3 had a motor vehicle accident, and they had increased insurance rates, and 6% of patients had their driver's license removed. So more recently, they looked at a study and they found that there was a 4-fold increased risk of automobile accidents which had hypersomnolence, so not just narcolepsy. And what they know is that the proportion of patients with narcolepsy who report issues driving is 4-fold higher. So this is an important aspect, is that if someone has narcolepsy, they need to be treated, and often will either repeat the mean sleep latency study on the medications to prove that they're not so sleepy, and so they are able to drive. And so that's often a point of contention with patients and families. So on to the medication and the therapies for narcolepsy. So the two components of narcolepsy that get addressed medically are the sleepiness versus the cataplexy, and we use two different categories of medicines to do that. Almost none of the medicines I'm about to talk about have an FDA approval for the treatment of narcolepsy in children. Most of them have either been studied for ADHD or have been studied in narcolepsy for children, but there's limited data on narcolepsy in kids. So the recommendations are based on the scientific evidence where it's available and on consensus if data is not available. So first, the medications for sleepiness. The treatment is primarily stimulants, so the sympathomimetic amines, and so these are the things like we're accustomed to seeing being used to treat ADHD. These tend to cause an increase, release, and inhibition of dopamine, and so it allows more wakefulness. And some of these medications also impact the norepinephrine function, and so they're important there as well. So these are the medicines that are used for sleepiness. The top 3 tend to be the short-acting, and so those are dosed multiple times per day, whereas the bottom 3 are the longer-acting or slower-acting medications and tend to be dosed only once per day. All of those are used for ADHD, and all of them are used as well for the treatment of sleepiness related to narcolepsy. The side effect of almost all of those stimulants, though, can be significant. Almost all of them result in a loss of appetite, nervousness, tics, headaches. Some of them can cause insomnia, and there's a risk for arrhythmias. So these are medications that it's probably worth checking an EKG before you start these medications, and following up with EKGs as well. Almost all the stimulants do have the risk for developing tolerance, dependence, and addiction, and there's also a risk of black market sale of many of these medications, as they have a street value that many of our patients are aware of. The drug that was developed for narcolepsy is modafinil, or it's the second generation is armodafinil, and these are stimulants that were developed that don't have the same risk of abuse. The mechanism of action is not as well known or elucidated as the previous slide, but they at least partially inhibit the active transport of dopamine and the dopamine reuptake. They are the first-line therapy for adults with excessive daytime sleepiness from narcolepsy. They do have less side effects, but they are not as efficacious, so they don't tend to have the sharp spike of a high energy, awake, or alertfulness that you might see with a dose of a medication like methylphenidate, but they tend to be a little bit more gradual and help the person stay awake throughout the whole day. And so you can see the 2 doses up at the top. The 50 to 200 milligrams is for the younger child, the children less than 9, and the dose above is the older children and early adolescents. They do have some side effects as well, the biggest ones being nausea, diarrhea, and headaches. There is a slight risk with these medications of Stevens-Johnson syndrome, but it is a low risk relative to many other medicines which may cause that. One thing that all patients who are started on modafinil or modafinil should be informed about is there's a decreased efficacy of hormonal-based birth control. So patients who are taking these medications and who happen to be sexually active need to be aware they should probably use other forms of birth control as well. So that's the treatment of the sleepiness. The cataplexy is mediated by different pathways. So these are the cholinergic pathways of the brain. And so the treatment here is really driven by more medications that can impact that portion of the neurotransmitter milieu of the brain. And so the SSRIs and some of the SNRIs are the most useful treatments here. So the medications which are most commonly used for cataplexy are venlafaxine, fluoxetine, sertraline. Those are the SSRIs or SNRIs. And their side effects tend to be weight loss, headaches, dizziness, or insomnia. Some of the older tricyclic antidepressants have also been used, things like clomipramine with the dose seen there. And those tend to result in weight gain, constipation, and nervousness, as well as profound xerostomia or dry mouth and eyes. And that directly relates to the mechanism of action. The clomipramine works as an acetylcholine kind of block, and so that dries everything out. It also tends to impair that cataplexy pathway. The last medication really to talk about is sodium oxybate. This was a treatment approved by the FDA for the treatment of excessive daytime sleepiness and cataplexy in patients with narcolepsy who are more than 16. And this therapy is really a novel therapeutic. It works on the GABA aminobutyric acid B receptor, or GABA B receptor. And this is a receptor in the brain that, when stimulated, it tends to promote slow-wave sleep and counteract REM sleep. It has a very short half-life, though, of only 40 to 60 minutes. So the dosing for this drug is really difficult, and then it has to be given 2 times per night in a divided dose. So basically you give a dose at 9 p.m. and another at 1 a.m. And so either the patient or their parent has to wake up and give the second dose. And it can be really challenging to do that night after night. Sodium oxybate has some pretty profound side effects as well, with nausea and vomiting and weight loss being the two most common. Anxiety and constipation tend to occur frequently as well, and there's an increased risk of suicidal ideation with this medication. So it should not be used lightly for sure. There's two other big concerns about this drug. The first is the way that this medicine is created. It has a very high salt concentration, and it can really lead to hypertension as well as increased thirst, and it is a respiratory depressant. So patients who are drinking alcohol should not be taking this medication at all. And it also has a really high potential for abuse. It can be used as a date rape drug, and so because of all of these concerns, it is tightly controlled, with providers and patients having to register with the manufacturer in order to receive this therapy. That being said, it is a very effective treatment for cataplexy and daytime sleepiness due to narcolepsy. So it's a good therapy that has its use, but it's not the most common therapy for narcolepsy. So as we get toward the end of our talk, narcolepsy has a huge impact on both the psychosocial, psychological and social kind of impact on people who have it. This next video is something that I found as I was trying to find episodes of cataplexy, and while it is a good example of cataplexy, it's what is being said and going around that I think is the most important. So we'll watch this and we'll talk a little bit about it.
Wake up, Sleepy!
I got her. You can turn it off.
No, I'm still filming.
With narcolepsy, clearly demonstrates the loss of muscle tone as she's playing badminton, or I think that's what they were playing with her friends. And so as soon as she got excited, she knew she was going to get weak and fall over, and so did they. So they decided to film her, and you could hear their laughing and saying, "Wake up, sleepyhead," and really minimizing the impact of muscle atonia caused by a chronic disease. That was one example, and there are many others that you can find on YouTube, but just talking to our patients and their families, many times a family will come for a consultation looking for a reason for the patient's sleepiness. And when we start to really talk about them, often the patients, if they have a sibling with them, it's almost always a brother who says, "Watch what I can make them do." And they will either jump out and startle them or tickle the person or try some way to provoke a cataplexy event. While that's helpful for diagnosis, because cataplexy is almost 100% pathognomonic for the disease, it's not so great that they've realized this and can make this essentially a party trick that they can do whenever they'd like. And we see this frequently with patients with this disease, where there's an impact, where because of people constantly teasing, or maybe them not understanding even what they have yet, where they feel that they don't understand or we're intolerant of what's going on. A lot of people report that sleep attacks occurring in conversation has led to alienation and social isolation. 50% of patients report their grades declined because of their narcolepsy. 30% report that they're embarrassed of their symptoms and didn't really want to go to school anymore because it was so profound. And very recent, the last several months, Harvard Sleep Health reports that in narcolepsy, the mental fogginess, like what Heather was explaining, makes it hard to concentrate. That memory issues and the autonomic behaviors can lead to feelings that they're just uncertain about their daily events and doubt really themselves. Like, are they crazy? Is this real? And sleepiness that causes unintentional napping at school or work can be embarrassing or problematic, leading to them getting poor grades or being fired from their job. It's a challenge across the board. So we know that narcolepsy impacts their social interactions. People with narcolepsy, as we said, are very adaptive. They will strain and struggle to stay awake whenever they're in social activities, like watching a movie with friends or at school. They may be confused or grumpy when they wake up in an unfamiliar place. The need to have naps at inconvenient times or places is certainly a hurdle. Hallucinations while you're talking to someone can be very disturbing to both the person talking and the person you're talking with. And then cataplexy at awkward times when laughing at friends at the party or at the movies or at a sporting event can lead to lots of questions maybe they didn't want to have to answer. So these are all challenges that our patients with narcolepsy face. I'm going to wrap up this last, I think, 3 or 4 slides talking about the school issues and some of the tools that can be implemented to help. So there are 2 different components, an IEP or Individualized Educational Plan and a 504 plan. And it took me a while to figure out the difference, so I'm going to share that with y'all. So the IEP is a plan or program developed to ensure that a child with a disability identified under the law and attending an elementary or secondary educational institution receives specialized instructions and related services. And this was created out of the Individuals with Disabilities Act. And that's important, is kind of how, like what the goal is. A 504 plan is a plan or program developed to ensure a child with a disability identified under the law and attending a school receives accommodations that will ensure their academic success and access to the learning environment. And that's the key thing, is the access to the learning environment, because this really came out of the rehabilitation law, and it's really a civil rights issue and access to school services. 504 plans have a much broader definition of disability. It's a limit of 1 or more basic life functions, which education is one of them, as opposed to an IEP where there's 13 categories of diseases to which you have to meet. Narcolepsy does meet both, but just so that people are aware. And here's just an overall the kind of contrast, IEP for 504. So the IEP gives you a blueprint for your special ed experience at school, whereas the 504 plan is a blueprint how you access learning at school. So what they do is the IEP provides the special education and services to meet the unique needs of the patient, whereas the 504 is the learning environment can be modified so they meet the needs of the child as adequately as anyone else going to school in that place. So a little bit different kind of criteria to meet. I've already talked about eligibility. The review for the IEP is annual. The 504 varies by state. And so if you're not here in Alabama with us, you need to check your local kind of laws and regulations. The funding is also different. The IEP is, there's no charge to the student or the family. States receive funding for eligible students. The 504 plan, there's no charge to the student or family, but states do not receive any extra funding for these eligible students. But if they don't provide it, they can lose federal funding if they're not compliant. So there's no carrot on that one, it's just the stick. So, but the content of the 2 plans, the IEP does set the goals and objectives and what they're supposed to do this year. It's a written document, and it specifies kind of what their goals are for their year and what services a patient will receive, as well as any accommodations to the environment, modifications, and do they have to participate in the standardized test. 504 plans, much looser. They don't even have to be written. It's specific accommodation support or services that will be provided, and usually has the name of who might be providing the service, but they're a lot less formal than an IEP. With that being said, we're going to talk with our experts, a few more questions, but these are some resources for patients or for providers. The first 2 are really more of patient information resources. The Narcolepsy Network and Wake Up Narcolepsy are 2 nonprofits which have a goal to provide informational resources to patients and caregivers of people with narcolepsy. The second 2 are more geared toward providers. The bottom one is a great book by Jody Mendel and Judy Owens. It's really an overview of pediatric sleep medicine, and if you're seeing patients who are pediatric, it's worth reading. The last is the Pediatric Pulmonary Center Sleep Education Web Content Modules, which in full disclosure I helped to create. This was a project funded by the Maternal Child Health Bureau where there are 6 free modules that provide CME for people who want to learn more about pediatric sleep disorders. So those are some great resources and references for you as you're learning more about narcolepsy and other pediatric sleep problems. As we wrap up, though, we do have our 2 experts who actually deal with narcolepsy in a very intimate and personal way. So I have a few questions for y'all. What has been the most important part of managing narcolepsy in your life that you've learned over time?
I think you kind of hit on it when you're talking about the sleep hygiene, and that's something that in the 5 years since my diagnosis, that's something that I definitely didn't know much about upon the initial diagnosis, and I've learned a lot since then. Things like limiting caffeine intake and kind of having a stopping point during the day for that so it doesn't interfere with my nighttime sleep. Things like waking up at the same time and trying to go to bed at the same time every night, and even taking the medication at close to the same time every day has a big effect on, I guess, the maintenance of the disease. It's something that if the nighttime sleep is messed up, there's only so much that the medication during the daytime can kind of compensate for. And I think another thing is just having the accommodations in place in college especially. That's something that I was very nervous about, transitioning from high school to college. In high school where I had it was a very small school, and my teachers knew me so well and were so accommodating, but I was nervous if I would be able to keep up with the pace in a college setting that was a lot bigger than what I was used to. But that's something that even before I started school my freshman year at Auburn, my mom and I met with an accommodation specialist, and we set in place even the ability to register for classes before my peers so that I could have a schedule that could work for me. Usually morning classes are a little bit trickier. And then before every semester, I'd meet with each of my professors and kind of explain narcolepsy and how that affects me, and usually that conversation kind of goes along the lines of from day to day it's handled, it's fairly well controlled, but when I get a sickness or a virus or something, sometimes those narcolepsy symptoms can kind of compound with that, and it takes me a little longer to recover from an energy or sleepiness standpoint from somebody else, and so they've been able to work with me on that, even rescheduling tests and submitting assignments later. So I think that that's been a big part of being able to live a normal life with narcolepsy.
Thanks for sharing. Yeah. Have y'all had challenges with driving? Is that a discussion you and your mom have had to have, or?
Well, you can answer that one.
As I shared earlier, I kind of had an unfair advantage in understanding narcolepsy because I was diagnosed with one of those other disorders, idiopathic hypersomnia, in 2000. So and I'm a pharmacist. It's really very much unfair advantage. I understood the medications. I understand living with daytime sleepiness, and I understand that as long as you take your medications appropriately. And I encourage her to have a backup. If she's going from Auburn to the beach with a group of friends, I remind her it's okay for someone else to drive our car if she needs to take a break. But also, she did have the follow-up multiple sleep latency test on medication. Mm-hmm. So, and really my goal as a parent was to encourage her to live a full life, not add unnecessary, she had enough anxieties of her own. I didn't need to compound that by extra limitations, just needed to trust that she would do the right thing. And as you can tell, she's very trustworthy.
Yeah. And I guess the last question that I have for y'all is, were there any lessons that you've learned dealing with narcolepsy these last 5 years that you wish you could share with either yourself 5 years ago or people who may be struggling with narcolepsy right now?
Yeah, I think so. I'd say that a big thing in handling narcolepsy and learning how it affects you is just having a lot of patience with yourself and sometimes with people around you. I think that it's something that I definitely I've learned a lot of courage and kind of being able to talk about it more comfortably. I think that upon the initial diagnosis, it kind of intimidated me. Like, I didn't know exactly, coming from a state where I was not in school, in high school, and very much so like taken out of normal everyday life. I was excited about the diagnosis because it brought an answer, but I didn't know, at what level I would be able to function, whether I would be able to keep up kind of the pace of my peers, if I'd be able to reach my goals and things. And so I think that made it difficult for me to talk about, but that's something that came with time, that as I learned that I might have to take life slower and take care of myself in ways, different than my peers, that it's not something that holds me back. And I think that just the learning over these past 5 years has just given me more courage and confidence in myself and knowing my abilities. So it's something that takes time. Yeah.
Well, thank you. I guess we'll open it up to any questions we might have received.
We haven't received any questions yet, but if you would like to ask a question, you can either give us a call or shoot us an email. That information is on your screen. I know we have a couple questions here in the studio, so we'll go ahead and start with those questions.
I have a question. Is there any specific diet or diet supplements that'll help narcolepsy?
So that's a good question, and one that I think we get asked a lot in clinic. There's not really good data to support a particular diet or a particular supplement that has been shown to improve or worsen narcolepsy that I know of. Occasionally people ask about versus high protein versus high carb versus, I don't even know, high fat diets, and there's really, to my knowledge, not been a study demonstrating one is more beneficial than the other.
Dr. Troxler, you mentioned some people might need a referral to a sleep specialist. What is a sleep specialist?
So a sleep specialist is a person who's completed a fellowship training in sleep medicine. Usually this is a one-year fellowship that is completed after a residency in either pediatrics, internal medicine, family practice, psychiatry, neurology, or anesthesiology. And so people who've completed a sleep fellowship are those who are able to read sleep studies and nap studies and deal with diseases like obstructive sleep apnea, narcolepsy, periodic limb movements of sleep, and others.
I have another question for Dr. Troxler. Are there any environmental modifications that might help narcolepsy, like light therapy?
So light therapy is an important therapy for some sleep disorders. It's not really been linked to being very beneficial for narcolepsy. Bright light therapy tends to be most effective if you're dealing with a sleep problem called a circadian rhythm disorder, where your sleep is shifted either early or late and you want to move it back to where you'd like it to be. But there's not any good data saying that bright light studies are helpful in narcolepsy. We do know that exposure to blue wavelength of light before bedtime for anyone is harmful in that it helps to make you more alert and not as able to go to sleep as effectively. But that's true whether it's narcolepsy versus somebody without.
Other than being cautious with swimming, are there any other exercises or fitness activities that should be avoided?
So I don't think avoided is the right term. One of the concerns for other types of exercises is could you get injured if you were to have either a sleep attack or a cataplexy event and you're by yourself. So the one that comes to mind is if you're doing heavy free weight lifting and you don't have a spotter or partner, that's probably not a good idea, because if you were to have a cataplexy event while bench pressing something, that could lead to some harm.
Could you clarify a little bit about use of caffeine, like energy drinks? Are those helpful? The medicines are stimulants, but yet part of the advice is to avoid caffeine.
So that's a good question. And so caffeine is a stimulant. It works on the same pathways that adenosine works on, which is one of the wake-promoting chemicals in our brain. Caffeine is often used by patients with narcolepsy to really self-treat. And so in the absence of other forms of therapy, caffeine could be used to try to help treat yourself. It's not the optimal therapy, though. Certainly, and we give the same advice to our patients with narcolepsy, is not to take their stimulant medication nor caffeine kind of in the afternoon hours, because that ends up with them having more difficulty with sleep during the night. So that's really how caffeine plays in. It's similar to a stimulant medication. And I think we have time for one last question.
One more question. All right, so what is the youngest age that narcolepsy should be considered as a possible?
So that's a hard question to answer. So the question is what age, the youngest age that narcolepsy should be considered. It's hard to tease apart patients who have narcolepsy if they're in an age where they still take daytime naps as part of regular childhood development. So most of the time, 4- and 5-year-olds are starting to get rid of their daytime nap. If by the time kids are going to school, and certainly by first grade, they're still needing a nap during the day, that's a little bit more concerning. But there's not a hard and fast and absolute of when you have to start thinking about narcolepsy. I think it's always important to listen to parents and to the caregivers and to the patients, because if they start saying, you know, I'm more sleepy than I think I should be, then we should be paying attention.
We had one question come in for the email, so I'll ask it to you real quick. If you know that one of your coworkers or friends has been diagnosed with narcolepsy, is there a way to politely ask how their medication is working if you're going to be riding in a car with them? Or does that make sense?
It does. So I think it depends on who you're talking with and your relationship with them. But it can be just a simple question. If you know a person that you're riding in a car with has narcolepsy and you feel comfortable, you can just ask, is your medicine working, or do you want me to drive, if you're concerned about it. But it really leads to the hard conversations, difficult conversations of asking people really how they're doing and trying to get down to the level where people will be honest with you. And there's not a very good, like a stock answer. It's really build the relationship and be willing to have open conversations that are honest with your friends and colleagues.
That's all the questions we have for today, and we really appreciate all of our guests being here. And thank you for watching. Have a great day.
Thank y'all.